Hi, everyone, and welcome. I'm Linda Tintawi, CEO of the Lustgarten Foundation. I'm so glad you're here for this very important conversation. There are over 250 people registered for today's first ever Lustgarten Live, and that's a pretty strong indication that you want and need more of these conversations. So that's exactly what we're going to be bringing to you for the rest of this year. We created Lustgarten Live to bring you these quarterly opportunities for you to hear directly from the scientists who are on the leading edge of pancreatic cancer research. Research made possible because of the generosity of the Lustgarten community. So go ahead and mark your calendars for June 30th, September 21st, and December 14th for the remaining sessions, and also June 18th for a bonus conversation on Juneteenth. And I'll share more information at the end of today's discussion about these exciting events. Before we get started, I have a few housekeeping items for you to share. First of all participants are muted, and we, however, want this to be as interactive as possible. We will have a Q&A after the main presentation. To ask questions, you're going to use the Q&A at the bottom of your screen. The chat function has been disabled. So we welcome all of your questions using that Q&A, and Dr. Rakeman will be helping our esteemed speakers today sort through all of your questions. If you want to follow us on social media, we'll be live tweeting. You can follow me at LM Tintawi and also at Lustgarten Foundation. And our hashtags today are LustgartenLIVE, early detection, and hashtag pancreatic cancer. And now I'm super excited to be able to welcome Debbie McGarity. We're happy to be able to kick off this exciting series with Debbie, who's the Director of Patient Advocacy, Neuroscience, and Oncology at Ipsen, one of our sponsors of this very exciting series. So hey, Debbie, so glad you're here today.
Thank you so much, Linda. It's great to be here with you today. It's great to have everybody on the line for, as you said, this very important webinar. Ipsen, we're proud to serve as the sponsor for Lustgarten Live, new kind of inaugural series of webinars. And what I'd like to share for the participants today, as they may or may not know, but Ipsen is a leading global size, mid-size biopharmaceutical company with a focus on transformative medicines in three key therapeutic areas: oncology, neuroscience, and rare diseases. At Ipsen, we're very committed to focus together for patients and society. Today, obviously, we come through via our oncology efforts to specifically help support the pancreatic cancer community. And we're proud to collaborate with the Lustgarten Foundation and its talented and dynamic team to help support this very important patient community. So thank you so much for this opportunity to welcome everybody, and I really hope we all enjoy today's webinar. Thank you.
Thank you. Thank you so much, Debbie, and thank you to Ipsen, and also a shout out to our other sponsor for today's session, Elevation Oncology. Now I'm pleased to welcome Andy Rakeman. Everyone, please welcome Andy, our Vice President of Research. And Andy, the timing for this conversation on early detection couldn't be any more timely, could it? So we're really excited about this today, and I'm glad that we have Dr. Vogelstein and Dr. Fishman, and you, of course, Andy, lead this conversation. So take it away.
Thanks so much, Linda. And you're exactly right. This really is a perfect time to be having this conversation. And it's not because early detection of pancreatic cancer is something new or something that we've just started talking about. It's something we've known for a long time. It is an issue and is a problem, and something that we need to be able to solve in order to do better for our patients with pancreatic cancer. But what's really different now, what makes now such a special time, is that long investment that we put into the science and understanding is really starting to pay off. So for the past more than a decade, early detection has been a focus for the Lustgarten Foundation. It's been an area where we've been funding lots of research. And just now, as you're going to hear from our esteemed guests today, Dr. Fishman, Dr. Vogelstein, those breakthroughs that have come from the science are now starting to turn into solutions for how are we going to be able to find pancreatic cancer earlier. And the next steps are really going to be taking those solutions and turning them into products, and then turning them into the impact that we need to do better for our patients. So that's really why it's such an exciting time. And I think the acceleration in the science, you can take my word for it. You're going to hear a lot about it from the two speakers today, but it also bears out in what the whole scientific community is doing. We're just coming off the biggest international cancer meeting across all tumors, and there, early detection of pancreatic cancer was a hot topic. There was a whole special session around it, as well as a number of other talks from leading scientists peppered throughout the meeting. So there's progress happening. There's lots of different things going on. And I think the other real sign that this is turning from more of just what we should do to what we are doing and turning it into practical solutions, you can see on the business side as well. I think you're going to hear today from Dr. Vogelstein about work he's been doing for a long time of trying to get a blood test, a so-called liquid biopsy, that Hopkins was able to spin out into a small company. And now that small company has been recently acquired by a much larger company, the company that actually makes Cologuard, to try to bring this into products with a sizable financial investment there. And they're not the only company. There's a number of companies that are pursuing this time. So again, also the business community is making this investment, that now is the time to really bring this to reality. And so I think, it's a very exciting time. It's a very hopeful time, but it's also the time where we need to keep driving and pushing forward. We're not there yet. There are still challenges ahead. There's more issues for us to solve and more things to move forward on. And I think you'll also hear a little bit about that today from Dr. Fishman and Dr. Vogelstein. But it's also important to keep in mind that just finding the cancer earlier is not going to be enough to get us to the point where pancreatic cancer is a curable disease. We also need to look at what are the other types of therapies. Are we developing new, safer, and effective therapies there? Do we understand who the right patients are to use them and at the right time? Can we personalize the use of those therapies? And that's why it's important to think of these different research priorities, not in isolation, but as pillars that help to support each other. So we do hope that you'll continue to come back in these meetings where you'll hear about those other advances and how we're coordinating across the different programs together to move this forward. But again, I won't go on and on because, like I said, this is a very exciting time for the research, and we have some very exciting guests joining us today to help lead us through what really are some of the latest developments and convince you all that this is an exciting time and time to get on board. So with that, maybe we can start to introduce our two guests, both joining us from Johns Hopkins. We have Dr. Fishman, who is a professor of radiology and radiological science at Johns Hopkins, who's going to talk to us a little bit later about some very interesting artificial intelligence work he's doing to help make imaging of tumors easier and faster. But first, we're going to hear from Dr. Burt Vogelstein, who I could go on and read you all of Dr. Vogelstein's titles and accolades, but that would use up the hour. So, he's the director of the Ludwig Center. He's a Clayton Professor of Oncology. He's a Howard Hughes medical investigator. But I think most importantly to me, he's the director of the Lustgarten Foundation dedicated pancreatic cancer research lab at Johns Hopkins, where all of the work that he's going to talk to you about today has been going on and really helping to drive us forward in this mission to be able to detect pancreatic cancer earlier. So Dr. Vogelstein, without further ado, I will turn it over to you to walk us through your presentation and hopefully get us all really excited about the new work coming out of your group.
Okay. So it's a pleasure to participate in this webinar, and I'd like to talk for about 15 minutes on the past, present, and future of multi-cancer detection tests, which, as Andy mentioned, we've been working on for quite a long time, and the future is indeed bright. So let's, of course, start with the past, and this, I think, is a very informative diagram. It shows in red the deaths from heart disease over the past 60, 70 years, and the deaths from cancer. And what you can see is that in heart disease, the death rate has plummeted, whereas with cancer, it's remained almost the same. And there are, of course, many reasons for this, but in my view, one of the main reasons is that the research on heart disease has focused on early detection, that is primary or secondary prevention, whereas cancer historically has focused on treating advanced disease. And if you look at heart disease, even in 2021, if someone has a massive heart attack or stroke, they're really no better off now than they were in 1950. But the difference is there are many fewer massive heart attacks and strokes today than there were in 1950 because of the preventative efforts that's in both primary and secondary prevention. And I think there's a major lesson for us cancer researchers from our cardiovascular colleagues. And that's why this earlier detection, this emphasis on prevention is just now coming into focus for cancer. Now, we started these efforts a long time ago, and that green arrow shows about 1991, perhaps because that's my training in pediatrics, and recognizing that historically the best way to save lives is through prevention. This is the old adage from our mothers, an ounce of prevention is worth a pound of cure. And we started this work in the early 90s, and as Andy mentioned, the first fruits of this work, the first FDA-approved test using DNA as a diagnostic agent for the early detection of cancer is this Cologuard test, which is made by Exact. But that's really just the tip of the iceberg. This lists the incidence of the major cancers occurring in the world, the 10 million new cancer patients each year. And the take-home lesson from this slide is that there are no screening tests available for the great majority of cancer types. There are already screening tests for colon cancer in the early 90s, and there are screening tests for breast cancer. But there have been none for the great majority of these cancer types, particularly including pancreatic cancer. So what can we do about this? And what has changed since the early 90s, since we began this work? There are really two changes. The first is knowledge. And in particular, we know that a small number of genes plays a primary role in a very large number of cancers. And that was totally unpredictable in prior years, decades ago. It was possible that the genes that contribute to pancreatic cancer, for example, would be completely different than the genes that contribute to ovarian cancer or breast cancer or colon cancer. It turns out that there's a huge overlap. There are many identities. So if one can work out a genetic test for pancreatic cancer, that same test could, at least in theory, be applicable to patients with many other cancers for detecting early disease in those cancers. And the second advance, what has changed, is the technology. What we can do routinely in our lab today would have been simply considered science fiction in 1990, just out of the realm of reality. But technology has advanced, and I'm proud that investigators at the Lustgarten Lab at Johns Hopkins have made some important contributions to that technology, particularly with respect to the earlier detection of cancer. And the test that we were now using, which was first published a couple of years ago, the lead author is Josh Cohn, who's an MD, PhD student in our lab, and remarkably gifted. Last year, for example, he was chosen by Forbes magazine as one of the 30 young people, that is under 30, who are most likely to set the world on fire in the next 30 years. And this test was based on the knowledge that I just presented. that we can look at just selected regions of 16 genes and detect many forms of cancers just by looking at that very small subset of genes. And here's a diagram from that Science paper with the 8 cancer types that were evaluated in that study. The most important thing is that these 5 cancer types, that is ovary, liver, stomach, pancreas, and esophagus, represent common cancer types for which there's really no screening whatsoever available. And in particular, and of course most important for those on the phone, is pancreas is one of them. And in this test, about 2/3 of pancreatic cancers could be detected by a blood test. And when I say detected, I mean retrospectively detected. We were looking at patients who had already been diagnosed with pancreatic cancers, as all studies must do to begin with. But what's really important is not to look in the blood of patients already diagnosed with cancer, but rather to look at normal individuals before they get cancer and see if one can detect those cancers in people prior to diagnosis by other means. And that requires a completely different design of the study, a prospective interventional study in which normal individuals are assessed. And the first such study to be completed was done by the Lustgarten at Johns Hopkins, and the lead author on that study was Anne-Marie Lennon, who's a member of the Lustgarten Lab at Johns Hopkins and also the chair of gastroenterology at Johns Hopkins. And in this study, there were 10,000 women enrolled, 65 to 75 years of age. They were chosen on the basis that they had no cancer. They had many other diseases, as one would expect for individuals of this age, but no patients were excluded for any comorbidities, that is, additional illnesses. And in all of these 10,000 people, the blood test was followed by a diagnostic PET-CT to confirm the existence of a cancer and to precisely localize it. And we were able to ask and address several questions through this study. Question 1, can a multi-cancer blood test prospectively detect cancers in individuals whose cancer was not previously detected by other means, by symptoms or signs? And the answer to that question, and the first answer that was ever been able to be accomplished to answer that question, was a resounding yes. There were 27 cancers, and you can see the sites indicated by these blue dots, that were first detected by the blood test in these women who were thought to be healthy before they had the blood test. Second, and equally important, can this test be used to intervene in the tumor progression process, to catch cancers early enough that they could be cured either with surgery or with conventional adjuvant therapy? And the answer to that was also a resounding yes. All the cancers indicated in red here had either surgery, usually surgery, or other therapies that were expected to result in cure. And none of these patients in red have had a recurrence of their cancer. We can't, of course, say they were cured, but at least during the length of the study, which is now reaching about 2 years, none of them have yet recurred. The third study, the third question, also important, is can such a test be performed safely? Because any test could lead to side effects, in particular, futile invasive follow-up tests. And the answer to that question was, again, yes. There were very few tests that needed to be performed, that is, very few false positive results, and no surgeries performed for unnecessary reasons in any, not a single one of the 10,000 individuals enrolled in the study. And the fourth question is such a test clinically useful, conferring more benefit than risk? Any test has risk, psychological risk, false positives, and that needs to be weighed against the utility of any test for the earlier diagnosis of any disease, whether it's cancer, heart disease, or anything else. And we don't know yet the answer to that question. The study called DETECT-A was designed to assess safety and feasibility, not clinical validity. It wasn't large enough to address that, even though it was a prospective interventional study. Now, our next prospective interventional trial, in which more than 100,000 patients will be recruited, will hopefully start within a year from today. It will be done after consultation with the FDA, so that if the results are successful, it could, at least in theory, be approved by the FDA for clinical use outside of a research setting. So that's a very exciting future development, which we're all looking into. Now, in the future, what is reasonable to expect? I don't think we'll be able to detect 100% of any cancers, including pancreatic cancers. But I look at it as, in general, we'd like to get 75% of cancers to be screen detected. That means to be detected by some screen, either a blood test, a mammography, colonoscopy. Right now, far less than 20% of cancers are detected in the U.S. by screening. They're mostly detected, that is more than 80%, by signs or symptoms, which means often it's too late to do anything and too late to spare the patient, and that later detection is responsible for virtually all the deaths from cancer that occur in the United States today. And I think it's a feasible goal over the next, say, 5 years or so to completely transform the landscape of how cancers are diagnosed. My hope is that there will be 75% which will be screen detected, 50% by liquid biopsies, and the remaining 25% by conventional methods. I think that's now within reach for the first time. And the other important principle for the future is what Andy mentioned. Earlier detection is not the only or sole answer to any cancer, including pancreatic cancer. But what is clear from many clinical studies is that the earlier a cancer is detected, even if it's not early enough to be cured by surgery, the more likely that a patient can be cured by any form of therapy, where it could be conventional chemotherapy, it could be the new generation of targeted agents, it could be immunotherapies. And for all those therapeutic types, it's now very clear that if you're looking at patients with relatively early disease, not late disease, once it's disseminated throughout the body, that those therapies can actually induce cures or long-term remissions. So my hope is that the joint research on earlier detection will come together, not be distinct from the research on novel therapeutic agents such as what Lustgarten is supporting in other centers that they provide funding for. And I'd like to acknowledge the Detect A team, and in particular the Lustgarten Foundation. These are some of the faculty members in our Lustgarten Center for Pancreatic Cancer Research. There are an additional 25 young people who work full-time in this lab. And I would also like to mention that although earlier detection research is in the mainstream now, as Andy mentioned, it wasn't always like that. And when Lustgarten started to support the research in our lab in 2008, they were almost alone. There was essentially no government support for it, no private philanthropy or very little, and no industrial interest. And I think that sea change has in large part resulted from the research that the Lustgarten has supported in our lab and other labs. And finally, I'd like to acknowledge our industrial partners who will be key to taking this test to the public and making it available to people outside of a research study in the future. Again, thanks to the Lustgarten and thanks to all of you for listening and tuning in to this webinar.
Thank you so much, Burt. That was fantastic. And I can say, you know, as a scientist, so much of what you talk about is exciting. It's always wonderful to see these stories where investment in fundamental basic research, the human genome, your work on the pancreatic cancer genome, this technology for being able to detect these molecules in very small amounts in the blood, when these come together and can turn into something real, it's always a magical moment. It's exciting to see that happen. And even also exciting from the point of view of how important it is, as you mentioned at the end, of foundations that are able to take risks on early stage projects with the knowledge that if they are successful, the reward is going to be so great. But then also sitting at it from my point of view as being in the honorable position of representing all of the patients and families dealing with pancreatic cancer, seeing this really turning into a solution that hopefully one day in the not too distant future will be impactful is the most exciting thing of all. I know I've seen a couple questions pop up already into the Q&A function. I know people probably have more. I encourage you to type those in. We will have some time at the end to talk through those questions and dig in on some of the specific issues that Dr. Vogelstein talked about and maybe some more general issues about earlier detection. So please keep those questions coming. But without further ado, I think we're going to hear now about a very different approach to getting at ways to detect cancers earlier, and specifically pancreatic cancer, where Dr. Vogelstein talked a lot about what is coming off of the tumors and winding up in the blood that could tell us that might be there. Dr. Fishman has been leading a project of saying, can we just take a picture directly of the tumor and find it earlier on, and not just have to rely on the very well-trained eyes of radiologists like him, but can we teach computers to do it better and faster and easier for us? And it's a very exciting project that Elliot's been leading at Hopkins, and I think you'll find is coming to a similar point where it's really taking these exciting technology developments and turning them into on the cusp of becoming products. So Dr. Fishman, can you take it away and tell us all about your research on the FELIX project?
Okay, thanks very much. It's really an honor for me to be here. And this is a project we've done basically the last 4 years, Dr. Vogelstein, myself, and a number of other people at Hopkins from many different departments, supported by Lustgarten. And just to take you back a little bit, hopefully you all can see my slides. One of the things that's been said, and this is an article we published a couple of years ago, was the fact that when you look at patients who are diagnosed today with pancreatic cancer, they've often had an imaging study somewhere between 3 months and 2 years before. And unfortunately, looking back, the lesion could have been found in about 30% of the time. You could see the lesion when it was potentially resectable, and now you're presenting and it's unresectable. So the question is, how do you get better at doing that? Now, we've been doing CT scanning for the past, I actually had to write an article. The first CT scan ever done by Hounsfeld was done in 1971. So CT is 50 years old, literally, I think this month. When I started at Hopkins, like a lifetime ago, we would get 30, 40 slices on a patient. If you found a mass that was under 4 centimeters, that was incredible. Technology evolved over the next decade, where instead of a scan taking an hour and getting 30 slices, you are now getting 100 slices. And then as you fast forward to 2020, we literally have, on a typical case we do of the pancreas, 2,000 to 4,000 individual slices, high resolution, thin sections, a study that maybe takes 10 seconds to acquire. Despite that, at the end of the day, the accuracy really hasn't changed. There are articles like this published that show across all of imaging, when a study is positive, 30% of the time, the findings are missed by the radiologist reading the study. Now, it's great to see things in retrospect, but the question was, how can we do things better? And if you think about it, the way people have always looked at CT, resolution's better, speed is better, but people looking at the slices, and I'm going to show you a number of examples, and maybe they looked at things reconstructed in coronal or sagittal planes. But at the end of the day, as Dr. Vogelstein mentioned, so much has changed in technology. When we started CT scanning, the computers filled up an entire room. We had to keep the room at 60 degrees so it wouldn't overheat. Now the computers all fit on a desktop. We can do 3D imaging, and I'll show you some of that. The development of augmented reality, but especially the development of AI. And 4 years ago, when we approached Lustgarten about doing this, AI was something that people thought was coming along perhaps someday. Now you can't read a newspaper where AI in medicine isn't front and center. I know a company called NVIDIA, which does a lot of the AI chips. We're at a meeting last week where they had 250,000 people. 25% of all the presentations were in medicine. If you go backwards 5 years, 1% was in medicine, and they were getting a few thousand people. So AI is really where things are going. And when we think about the ability to detect things on imaging, now, Dr. Vogelstein spoke about screening. Now, I'm not suggesting we're going to screen patients with CT, though on high-risk patients, we actually do that now. But if you think about in the US, for many different reasons, 50 million scans are done on a yearly basis. And many of those people, we are looking at the pancreas, and perhaps in a sense, we are doing screening already, though we don't recognize it. So I'm going to share with you a little bit of what we can do. If you think about CT, everyone in the audience has probably seen CT slices, but this is really what we're looking at. This is the computer creating a 3D map. There's the pancreas, there's the spleen, the liver. That's really what we're looking at. And our goal is, by looking at the texture of the gland with AI, or with even us looking at these reconstructed views, you're able to pick up pathology where it's smaller. People talk about a small pancreatic lesion as 2 centimeters, but 2 centimeters is really kind of late. We want to be in the 1 centimeter or less range. And just to show you the variability, this is the same patient. These are scans that are a few months apart, but when you look at the first scan, this patient had vague abdominal pain, and this scan was read as negative. And then you just come back a little bit later, and now you see the patient has multiple liver metastasis. Now, if I look hard at this first scan and I just scan through the images, I am able to, and maybe in retrospect, see what ends up being the tumor. Here, the tumor was unresectable. Here, it would have been resectable. Again, it was missed. If you do things like texture mapping, you can accentuate the presence of disease. So here's very subtle textural changes, which shows you the tumor. And of course, here it is going to be a few months later where it's much more obvious. So again, can we use computers to accentuate what we see and look for normal and abnormal? This case seems very obvious, but this was a patient who we looked at where it was missed. This is a scan that was about 4 months before, looked almost identical, but this was read as normal. But there's a lesion here that would have been imminently resectable. If we had this processing, would have become more obvious to that radiologist. Look how obvious this thing is right here. Here's a normal tissue. There's the lesion. So can we accentuate everything? Can we have computers help us making the diagnosis? And again, you also can see, and I won't have time to discuss this, but we also can show the vessels. So not only can create these 3D maps for lesion detection, but also for patient management. At the end of the day, surgery is the key way of treating pancreatic cancer these days. And of course, whether a patient is or not resectable often depends on the vessels. And we can increase our accuracy there at about 20 to 30% as well. Now, with the Lustgarten Foundation, what we did is try to build at the medical school and the engineering school this program combining computer scientists and radiologists and pathologists and oncologists, putting everything together with the state-of-the-art technology, then to develop algorithms to teach us how we could detect early pancreatic cancer. The first work we did was literally teaching the computer how to recognize the various organs in the body. We had 5 full-time people literally segmenting each of the scans. That's the pancreas, there's liver, there's spleen. At the end of the day, when you look at AI, and this has been shown whether it's looking at driverless cars or a space satellite or any type of analysis, you need good data. Everything is data. And you can see from those images, we created the 3D maps of the body. We then spent more than a year teaching the computer to recognize everything. This is a regular CT scan, liver and spleen and spine. This is one of our experts drawing the liver and the spleen and the stomach. This is the computer now automatically showing you the accuracy. So the computer was as accurate as the best radiologist. And then when you look at the pancreas, here's the pancreas on CT. There's the annotation, that's us, and that's the computer. So we're now able to find the computer to be able to find the pancreas, find all the organs, which becomes critical if you're trying to detect disease. We then tried to teach the computer how to recognize pancreatic cancer. The same process, look at thousands of cases, individually segment the cases, particularly smaller tumors, but a range of tumors, teaching the computer how to be able to recognize pancreatic pathology, developing a range of algorithms that did not exist. I think one of the things we did, Alan Yulee and his team in computer science, developed a number of algorithms which allowed us to recognize the pancreas, create these 3D visualizations of the pancreas, and then develop networks that would allow us to pick up early pancreatic cancer. So again, the goal is, if you think about looking forward, a patient would have a CT scan, the information would go to a computer that would automatically analyze the patient and then detect the presence of disease if it was there. And here's just a good example. This is a patient axial CT showing you a pancreatic mass with a dilated pancreatic duct. Here's the computer's prediction. Found the tumor, found the dilated duct, and you could see the red is the tumor, blue is normal pancreas, and kind of the turquoise is the pancreatic duct. So now you have the computer recognizing everything in detail. And then, of course, the key is not picking up large tumors. But here's a great example where a radiologist would draw the tumor, and here's the computer automatically finding yellow is the pancreas, and here's the patient's tumor, 1.5 cm. Or in this example, another small 1.4 centimeter tumor. That's the radiologist, and that's the computer without any intervention. So now we've been pushing the work to be able to pick up ever smaller tumors, and we're working on with different institutions getting smaller and smaller cases, because the key, of course, is early detection, and early detection and outcome is really dependent on the size where you can pick up tumors. We also spent a lot of effort trying to teach the computer to think like a person. I've heard many talks about driverless cars. You can't teach a computer to drive a car. You have to teach a computer to think like a person driving a car, where if it gets darker, if it starts raining, 1,000 things can happen. So we teach the computer to think like a radiologist or oncologist, find the pancreatic duct, look for transitions so that we can see the presence of ever smaller tumors. We've also spent a lot of effort in radiomics, which is a way of analyzing data and trying to be able to detect specific features of images that can be used to detect the presence of disease. And radiomics has become very popular over the last couple of years. I can't go into detail now, but it's a way of looking at different features. And what's been shown is that cancerous tissue and normal tissue and inflammation all look different. And the radiomics can be very sensitive by looking at a number of features. It's a lot of image processing. And in fact, the work we did with Lustgarten, we looked at 500 features to be able to detect. Now, it ends up about 10 features were critical, but we looked at numerous features. And when we were able to do that, we were able to pick up ever smaller tumors. And we were able, and here's the process of trying to create fingerprints for specific types of pancreatic cancer. We looked at neuroendocrine tumors. We looked at autoimmune pancreatitis, the range of pathologies to make sure we were best at being able to develop programs that allow us to detect. And we were able to find, we looked at normal patients and we looked at pancreatic cancer patients, that the fingerprint, the actual signature of the patient's tumor was different than normal pancreas. And when you look at the accuracy, it approached 99%. We can look at a large data set and say normal or say cancer. And so that was very exciting. With radiomics, you don't particularly find a tumor, but you know the tumor's within the pancreas, and then the deep learning finds the tumor. And you can see the accuracy. If you looked at the accuracy of the computer compared to, say, a radiologist, a well-trained radiologist, the radiologist would be about 20% less. The best radiologists are probably were in that 80% range when we tested it. So high sensitivity, high specificity, and we've been pushing the envelope and trying to do that better. And again, this whole process, we can't have computer scientists doing this, and we can't have individual people doing this. It needs to be a process where it automatically happens, where everything goes into the computer within a split second analyzes the data and then sends the image to the radiologist who's reading the scan to be able to read it more accurately. And again, this combination of deep learning and radiomics seems to us to be the best process. And then combining that with some of the 3D imaging, the cinematic rendering I showed you, really provides the opportunity for a turnkey system. As Dr. Vogelstein mentioned, it's not going to be good if it's sitting in a research lab at Hopkins or other big institutions. It needs to be at every hospital, at every imaging center, whether it's small or it's large. And the only way we can really change the numbers is really to change how we do things. I think this implementation of AI is going to improve early pancreatic cancer. And the fact is, it's my belief that every tumor, anything in cancer, is going to be impacted by AI, whether it's the work Burke's doing on the cellular level or the work we do on the imaging level. I think with a 30% error rate, you need all the help you can get. You can imagine the change if we can just pick up that 30% earlier, the number of lives that will be saved on a yearly basis. And again, one of the things we're also doing is not only looking at AI on the FELIX project for lesion detection, but also looking at different factors, including the liver now, to be able to predict outcome. I think without Lustgarten's support, this never would have started. When we started doing the AI work, it was something that people theoretically thought it might be possible to do. Now, as I mentioned, AI is everywhere. And I think we're looking forward to continuing to do this to really make a difference in our patients' lives and all our lives. And all of us at Hopkins are particularly grateful to you all and to the Lustgarten Foundation for their trust and their support. And thank you very much.
Thank you, Dr. Fishman. That's incredible. And I would say two things off the bat that are immediately striking is one, those images, especially those computed 3D renderings that you can put together, are beautiful. It's stunning to see that much detail in the organs and in the body, and it's amazing to see. And secondly, it's so grateful to have been able to bring you over to the team to be taking this on, because it is a big and complex problem and really takes a lot. And I think your experience coming in and from both from the radiology and from the 3D imaging side has really been able to accelerate this program much faster than it would have otherwise. I will also say this personally, that this approach touches close to home for me. I know my mother a few years ago, fell, I believe broke a rib, ended up going for an x-ray. The radiologist was attuned enough to detect a spot on her lung that was small enough that she could go in for surgery. Had stage 1 lung cancer. They were able to do analysis on the tumor and identify specific drugs that would be very effective against her tumor. Somebody of no risk, never smoked, and now is 6 years going on 7 years completely cancer-free. And I hope that kind of story that we always feel so fortunate that she was able to be part of becomes very common for for people dealing with pancreatic cancer, where we'll be able to say either found it on a scan that I was getting for another reason, or it showed up in this blood test that I was getting at my physical, was able to get surgery. We understood what was happening with the tumor because we could do all this deep analysis and get them on effective treatments, and really hope that becomes the common story and not the uncommon story as it is today. So I know that there's a lot of questions that have come in, and we'll get a chance to discuss a little bit. But maybe what I would, before we get into questions specifically about the two technologies that you two talked about, maybe we can take a step back a little bit and put this into the context of what all is happening around trying to detect cancer earlier. So both of you talked about approaches that would be used in people where they're of average risk, or we don't know if there's any underlying risk. But what we hear from a lot of people in the questions today, and every time we go out and talk, is, well, somebody in my family had pancreatic cancer, my mother, my father, a brother, a great aunt, something. I've been told I'm at family risk. What does that mean? And what should we be doing today for people who, either have a family history or a known mutation moving through their family? So I don't know, maybe Dr. Vogelstein, can you just talk a little bit about what we know about inherited risk for pancreatic cancer and kind of what the recommendations are today that people should be doing? I think you're on mute, Dr. Vogelstein.
That's a really important question. About 15% of pancreatic cancer patients have a history of pancreatic cancer in their family. And because this is a devastating disease, it's particularly important those patients to be careful. And the screening that I described would be particularly applicable to patients with a family history. Let me give you an example from the colon. People who have a family history of colon cancer are advised to have testing, whether it be Cologuard or colonoscopy, starting at a much earlier age than the general population. So instead of 50 or 55, it could be 30 or 35, because patients with a family history often develop cancer at an earlier age than those without a family history. So hopefully, as these blood tests become further developed, they will be applied to high-risk patients in a somewhat different way. They'll be screened earlier, number one, and number two, the threshold for suspicion of a lesion will likely go down. So that's one class of patients at risk. A second class of patients at risk, some due to hereditary causes, some not, is those with pancreatic cysts. Now, patients with pancreatic cysts, at least with some types of cysts, are at much higher risk for pancreatic cancer. And in those patients, it's particularly important to be under the care of a gastroenterologist who's aware of that risk. And in those patients, instead of a blood test, they can and will soon be able to have cyst-based tests. So a sample from their cyst, which is routinely taken during their exam, can be subjected to the same sort of molecular genetic analysis as as I described for blood, and that's already been worked out. Again, work exclusively supported by the Lustgarten, and those sorts of tests are also coming online and are going to soon be available to outside research studies. They look very promising in having a high sensitivity and also important in saving patients from unneeded surgery, because sometimes it can be very difficult to tell what those cysts are.
Excellent. Thank you, Dr. Vogelstein. And I think you touched on a couple other questions that had come up through that about what's the status for using these blood tests in high-risk patient groups and moving forward like that. So maybe on a related question for you, Dr. Fishman. So currently for people that are at high risk, the protocol now is that they'll get regular CT images or MRI images. So two questions coming on this. So the type of technology that you described, is that something that could also be applied to MRI or other imaging approaches? And is it something that then in also in these patients where you're already screening for something happening in the pancreas, would it also help you to be able to detect things earlier or more easily?
Right. That's a great question. I think there's two things involved. One is detection, but the other thing is classification. We kind of know from CT and MR, if you look carefully at CT or MR scans, 5 to 20% of patients are going to have some sort of pancreatic cyst. The question is, do you need to follow every one of those patients? Obviously, most of them are not significant, but the question is, how can you be certain of that? So one of the things we're trying to do, and actually looking at some of Dr. Vogelstein's data with him, is can we predict by looking at a cystic lesion with, whether it's with 3D, whether it's texture mapping, whether it's radiomics, and we predict which cysts are going to be worrisome and which aren't going to be. I think that's the challenge, and we often, we follow many patients. We have a big cyst clinic at Hopkins, multidisciplinary. We follow many patients where, the question always becomes, how long do you follow somebody for, right? You used to think about cancer 5 years. Well, the latest recommendations for following a cyst are 9 years. And the person who wrote, I know a good friend of mine was the lead author in that. I said, well, I never heard of anything that you follow. For 9 is not a number. I think Roger Maris, since you're in New York, he was number 9, but nothing is 9 years. And he goes, well, at about year 7, I'll rewrite the article and we'll extend it out. So it's this idea of, if you have to follow every person with cysts, the cost to the system would be just astronomical. There wouldn't be enough scans to follow them. We're trying to put a lot of effort in trying to figure out which are the worrisome lesions. I think we have a cyst clinic, and sometimes, the recommendations that we have versus outside recommendations will vary half the time. I think that's one of the big challenges. And I think the blood test, the work that Burt and his team have done is really going to be the big differentiator. I think you need something that can quantify what do you worry about, because I think maybe AI will be a good, we're looking at AI, looking at cystic lesions, trying to see, just because I can't tell the difference by looking doesn't mean that it's not there. I think AI perhaps should be able to tell which might be worrisome cystic lesions. So I think that whole area, whether it's from the molecular level like Burt speaks about, or the more of a global level that we speak about, I think together, I think it's going to make a major difference.
Thanks, Dr. Fishman. And one other group that people often think about of moving forward, so those who were detected early enough to have surgery or be treated effectively and are now in remission, then there's also the worry about, is this going to recur, and what do we need to do to monitor recurrence if it comes? So are these types of approaches that the two of you talked about also going to have application in terms of monitoring patients for either recurrence or changes in disease?
That's an excellent question, and also something that we've been working very hard. This type of research is often called minimal residual disease detection. And together with some of our colleagues in Australia at the University of Melbourne, we've been studying that for several years in colorectal cancer patients and now in pancreatic cancer patients. And the newest technologies, many of them invented by Josh Cohn, the student I mentioned before, are extraordinarily sensitive for detecting residual disease in these patients, often months to years before they appear radiologically. And we expect that in the foreseeable future, every patient with pancreatic cancer will be followed by these blood tests. It's actually much easier technically to detect a recurrence than it is to detect them before they're diagnosed for technical reasons. You know what you're looking for. But my expectation is that this will actually become standard of care within the next few years and will immeasurably help tell patients who needs to be treated when, whether they need to change their therapy, whether they should undergo experimental therapies, really a dramatic change in the way patients are managed.
Thanks. And so we have a number of questions still to get through, and we're not going to have time to get to all of them, unfortunately. So we will try to follow up by email with people who sent in questions to get you answers. But I do want to come out, there's one set of questions that come in that I think show how excited you got the whole audience here today. And it should be a quick answer here. And it's the people asking, how do I get in the study? How do I get the blood test? What are we going to do next? So maybe Dr. Vogelstein, you just give us a quick answer of what really is the next steps and how can people become a part of those next steps for the test?
There will be clinical trials which will be advertised. Now, because it's prospective, it's difficult. You can't handpick people because that would change the underlying statistics. But there will be, hopefully, ways for patients who are especially at high risk to enter into high-risk studies. And as you know, Andy, we've spent a lot of time trying to figure out the design of studies for high-risk pancreatic cancer patients. And those discussions are ongoing. But they will be one of the first groups of patients to be evaluated at least in a research setting, but hopefully later in the public as well.
Okay, great. So stay tuned. So as these studies launch, you will be hearing about them, and there will be opportunities to look into if you are eligible, how to get to participate in these studies as they move forward. So Dr. Fishman, Dr. Vogelstein, thank you so much for joining. I think this was informative as always, exciting as always. And I think the hardest thing to communicate often is that this really is the tip of the iceberg, and it represents so much more that's going on in your groups around the country, around the world to really tackle this on. And I hope people leaving with that sense of hope and excitement that I started with, that this really is a different time for earlier detection research. And we're starting to see this not just as we should do it or we have to do it, but we are going to be able to do it, and it is coming. So thank you so much for joining us. And now I'll invite back Linda Tantawi, who's going to again help to thank you and to help close us out today.
Thank you, Andy, and thank you, Dr. Fishman and Vogelstein, for the terrific talk. And I can see from the participants in the chat that they were just thrilled to have your expertise shared with them in such an intimate fashion. And we look forward to being able to share this webinar widely with our community. And again, we want to make sure that everyone knows we have an upcoming series still, June 30th, where we will bring you live behind the scenes in our lab here at Cold Spring Harbor. And again, we have a really special webinar on June 18th in celebration of Juneteenth. And that will be a terrific conversation around the higher incidence and death rates of pancreatic cancer among Blacks and African Americans. and Dr. Avery Posey, who's an assistant professor of pharmacology at the University of Pennsylvania's Perelman School of Medicine, who was also our inaugural recipient of our Career Development Award honoring Representative John Lewis. So thrilled that he'll be joining us for that very important conversation. We know that research produces real results. And what struck me today was that both Dr. Vogelstein and Dr. Fishman emphasized the role of the Lustgarten Foundation in taking a risk and supporting their important research in AI and in the blood biopsy when no one else was willing to support that research. And we are able to provide these funds only because of the support of the Lustgarten community. So again, thank you to our community for all of you do to help us drive this research forward so that we can transform pancreatic cancer one day into a curable disease. We encourage, of course, our community to donate to these early detection initiatives and to continue to support the important work of Drs. Vogelstein and Fishman and all of the research that we fund. We're again thrilled that you were here today with us. We are out of time now, but we'll never be out of touch. And please feel free to email us, stay in touch, and we'll be making this webinar available to you very quickly on our YouTube channel. So we hope to see all of you on June 18th and at our other webinars. Sign up early and we'll see you all then, and have a great rest of your day. Thanks, everyone.
Thank you.
Bye.
Thank you.
Thanks, Dr. Vogelstein and Fishman. Thanks, Andy.
Thank you.